recognized websites, the POCUS.org. Thank you, Dr. Yasser. We use it a lot in our unit. And the NIOPED Academy for Virtual Education in Medicine. And he designed the Manitoba Neonatal Educational Learning Management System there. And his key contributor and his key contributions where he founded the lung ultrasound program, which replacing the X-ray for diagnosis of lung disease, as have been said in the last session. And his research interest in hemodynamics and point-of-care ultrasound and physiology-oriented practices very well known as a neonatologist, and he's received several recognitions and awards. The last one, I think, the Ronald Dohman Innovation Award and the Emerging Lead in Neonatology Award from the Canadian Pediatric Society. So welcome, Dr. Yasser, and we can start now.
Welcome, everyone. Over the next 30 minutes, we will summarize cardiovascular support stewardship. And I have two main objectives. First, I will go over a summary of cardiovascular physiology. Second, I will discuss the four main categories of cardiovascular dysfunction with the relevant support. And I have each one of the four categories has two main phenotypes. So the style of this presentation is 2 by 2. Everything is arranged in 2 or multiplication of 2 for easier recall and to increase your knowledge retention. Let me start first with this introduction. The history of medicine passed through 3 main stages. The first stage since the beginning of human being until recently was based on experience and experience-based medicine. And since 1990s, we have been in the era of evidence-based medicine. And then now we are gradually shifting to the new era, which is precision-based medicine. What we have from evidence-based medicine for the last 30 years is summarized in this slide. Evidence-based medicine highlighted 4 things are good for outcomes and 4 things are bad for outcomes. Good for outcomes, we have 4 natural things, including breastfeeding, skin-to-skin, delayed cord clamping, and surfactant. Then we have 4 interventions are good for outcomes, including antenatal steroids, caffeine, CPAP, and cooling in HIE. And then we have 4 things are known to be bad for outcomes, including invasive ventilation, antibiotics, cardiovascular drugs, and oxygen therapy. So now we understand that cardiovascular drugs are not really good for outcomes. So we have to be very careful about using these interventions or medications in our practice. What about the precision-based medicine, and what's the difference between evidence-based medicine and the new concept of precision-based medicine? To summarize, precision-based medicine includes assessment, check, management, and respect. Assess of 2 main things: individualized assessment and real-time monitoring and implementation of point-of-care ultrasound. Then check of evidence-based practice. Now you realize that precision-based medicine still respect evidence-based medicine. And then also check data integration and analysis, then management based on interdisciplinary collaboration and applying physiologic-based treatment, as we will show in this presentation. And then respect ethical and regulatory considerations according to your institution, and also respect the outcome. When you apply any management or any intervention, you have to be sure that you are getting good outcome at the end, either short-term outcome or long-term outcome. Now let us summarize cardiovascular physiology over 5 minutes. The heart starts to pump the venous return out as cardiac output to stroke volume. So pumping out the venous return as a stroke volume, which represented as pulse pressure, not systolic blood pressure, represented as pulse pressure. So pulse pressure, now we understand it reflects myocardial performance and also reflect the afterload, because if you have resistance, the afterload will increase. So the pulse pressure should increase to overcome the resistance. And then once the blood pumped out of the heart, the large arteries, including aorta, will expand due to elastic recoil, expand to absorb part of the pulse pressure and then recoil. And then with recoil, will push the blood forward. This pushing will maintain and create the diastolic blood pressure. So we have two things with the pump. Number one, it reflects myocardial performance and then afterload. And then in larger arteries, stick recoil, absorb the pulse pressure. Number two, this recoil push the blood forward and create the diastolic blood pressure. Then we have the arterioles. Number three, arterioles maintain systemic vascular resistance, and also this vascular resistance is mainly reflected on diastolic blood pressure. So the maintained vascular resistance will maintain the diastolic blood pressure and reduce the variability of this pressure over time. And then we have the capillaries, and the capillaries will be responsible for exchange with tissues, number one. Number two, control vascular osmosis and volume. Remember, in this presentation, we are describing almost everything in cluster of two for easy recoil. What determines the perfusion to the tissue? It is mean blood pressure. So the perfusion pressure is usually reflected as mean blood pressure. And then in the veins, which is a capacitance reservoir of blood, number one, and also the venous oxygen saturation used as a reservoir in case of hypoxemia. So the tissues can use the oxygen saturation in the tissues before drained into venous compartment. Then we have at the end the lymphatics, which drain fluid and protein, and then responsible also for immunity. So there's two functions for each part of the cardiovascular system. And then we talked about the tissue perfusion pressure represented as mean blood pressure. It is directly proportional to two things: the cardiac output or the blood flow and systemic vascular resistance. So the perfusion is dependent on two main factors and should be maintained normal: cardiac output and systemic vascular resistance. So to summarize in one slide, stable hemodynamics, it is equal to normal resistance and flow. So stable hemodynamics means that you have a right heart pushing the blood against the pulmonary vascular resistance to get a normal flow, and normal flow pass through the lung back to the left heart, and left heart eject the blood through systemic vascular resistance when we have normal afterload to get normal flow. And this will be represented as systemic pressure. And the other hand, the resistance of the pulmonary circulation and the flow represented as pulmonary blood pressure. And then we'll get the venous return back to the right heart. You know, two things related to systemic circulation and another two things related to pulmonary circulation. You know everything about hemodynamic physiology that you need to assess for any unstable patient. So for systemic circulation, if you know how to calculate systemic blood flow indices, you need the blood pressure, mean blood pressure, pulse pressure, and you need to know how to calculate cardiac output by echo, and then get tissue oxygen saturation by near-field spectroscopy, and then calculate systemic vascular resistance, which is quite easy. It is mean blood pressure divided by left heart cardiac output. The same thing for pulmonary blood flow. If you know how to assess pulmonary blood flow as right heart output, typically you get arterial oxygen saturation from the pulse oximetry, and then the little bit more advanced calculation or estimation of ventilation perfusion matching through perfusion isotope scanning. And then number two, how to calculate pulmonary vascular resistance based on pulmonary artery pressure and also the cardiac output. If you know the 2x2 things in this slide, you know everything about hemodynamics. But typically, you need almost 1 year of training in hemodynamics. It is training shared between pediatric cardiology and neonatal expert in hemodynamics to get certified in hemodynamics, which is a style in North America. So the physiology or the physiologic phenotypes of cardiovascular instability can be summarized in this slide. And this can be summarized or categorized into functional and anatomical or structural. Again, remember the number two. Everything in this presentation is categorized into two for easy recall. So functional we have either arterial-related issues or myocardium-related issues or related to abnormal rhythm. Anatomical, it is anatomical. The arterial-related issues could be arterial vascular. So loss of vascular tone, which means loss or decreases systemic vascular resistance or vasodilatory shock. So the arterioles as tone and what's contained inside as a blood. So when you have hypovolemia, you will get also low diastolic blood pressure and hypotension. And then myocardium, represented as venous vascular, when you have venous hypertension or congestion because of poor heart performance, so blood will be stagnant in the venous compartment, which is more chronic issue, or could be pump powers, the heart pump, as myocardial systolic performance is reduced. So it might be presented as acute cardiogenic shock, or also could be related to vasoconstrictor physiology or shock. So the afterload increase the heart pumping against high resistance, typically the same like systemic hypertension in adults. Whereas it could be tachyarrhythmia like SVT, or bradyarrhythmia as heart block. Anatomical issues, we have two main categories: obstructive like hypoplastic left heart or coarctation, or restrictive like cardiac tamponade by pericardial effusion or tension pneumothorax. So let us discuss one by one. Arterial vascular, we have vasodilatory shock. So the blood is stagnant in the vascular compartment with reduced blood flow to the tissues. Typically have low systemic blood flow, low systemic vascular resistance, but unaffected the pulmonary vascular resistance and the blood flow on the other side. In this category, we can diagnose it by two, too low and too normal. So too low, the first one, low diastolic blood pressure, low mean blood pressure, and low also systolic blood pressure. All of the blood pressure variables are low, but with maintained pulse pressure. Also, we have low systemic vascular resistance. So low blood pressure variables except the pulse pressure and low systemic vascular resistance. And also by echocardiography, normal systolic heart performance, or sometimes even hyperdynamic. As you can see in continuous blood pressure tracing or monitoring, you can see the blood pressure variables or decreasing, but with maintained pulse pressure, which is the red zone between systolic and the diastolic. And then the medication that makes sense to be used in this situation, vasopressors like norepinephrine or vasopressin, steroids in the resistant cases, because steroid might increase the sensitivity of vascular tone to circulating catecholamines, or can be adjuvant drugs like correct acidosis if there is acidosis, and we are using sodium acetate or citrate. For that, we are not using sodium bicarb, and then treat any underlying cause for vasodilatory shock like sepsis, for example. And as you can see in the tracing, just after use of norepinephrine or vasopressin, the blood pressure improved. The common scenarios here: septic shock, systemic inflammation. Keep in mind, we're talking about physiology. Septic shock can be multiple physiology, can be vasodilatory shock, or can be hypovolemic due to a capillary leak. So we have to differentiate between the etiology and physiology. And then number two, suprarenal dysfunction in two main conditions. Suprarenal dysfunction is common in very preterm infants, especially late beyond the postnatal transition, or also in HIE. Again, remember, everything is organized in 2x2 sequence, so you can easily recall the knowledge in this presentation. In these cases of vasodilatory shock, which doesn't make sense. When you have vasodilatory shock, you need to use a specific medication, which is vasopressor. Or give unnecessary fluids, just to give fluids without any good response, and that might be also dangerous because you may overload the heart without any improvement of the cardiovascular performance. Then the second part is hypovolemia, and the hypovolemia is simply you have the blood contained in the vascular compartment decreased, or the fluids decreased due to loss of fluids, third space losses, or polyuria, or any other reason. Or it could be related to shift of the blood through the PDA in premature infants. So you have systemic shift of the blood from the systemic compartment to pulmonary compartment. So in this situation, you have low systemic blood flow, but normal or high systemic vascular resistance, because the vascular resistance might increase in the body to compensate for the low flow. That's really common and expected in dehydration, especially in older ages children. And then the pulmonary blood flow and the pulmonary vascular resistance are unaffected. The diagnosis in this situation is 2 by 2. 2 low variables, low pulse pressure and low cardiac output, and 2 normal variables, systolic blood pressure and heart performance. Medications, typically fluids, steroids and capillary leak syndrome, and adjuvant medications like sodium citrate or acetate to correct acidosis, and then treat any underlying cause. Common scenarios, dehydration, capillary leak syndrome. Less common scenarios like BDA shunt in preterm infant, high urine output, or stoma losses like ileostomy losses. Common mistakes, use of diuretics in oliguria. Typically, oliguria in this case is related to dehydration, so using diuretics might cause more harm more than help. And then use of inotropes, because inotropes might reduce the diastolic filling of the heart and might worsen the filling and also worsening the cardiac output. Next, we have the venous vascular or venous congestion, and congestion related to chronic cardiomyopathy, so the blood is stagnant in the venous compartment. In this situation, we have low systemic blood flow, normal systemic vascular resistance, and also normal pulmonary resistance and the flow. The 2 by 2 expected variables for diagnosis. Number 1, dilated heart with poor function. Number 2, congested venous compartment, including hepatic veins and all of the systemic veins, but normal blood pressure usually and normal pulmonary functions. Medications, we can use afterload agent like captopril, preload agent like diuretics. Adjuvant medication, control fluid balance is very important, also treat any underlying cause. Common scenarios, cardiomyopathy, especially metabolic or chronic types of cardiomyopathy, congenital pumps like VSD or atrioventricular septal defect, usually clinically presented about 4 to 6 weeks after birth. Less common scenarios like hypertensive cardiomyopathy and myocarditis. Common mistakes in management of this situation, use of inotropes. You should not use inotropes in cardiomyopathy, and also use of extra fluids might cause more fluid overload. Then we have pump failure or cardiogenic shock. And sometimes also it is associated with vasoconstrictor physiology. So the failure can be intrinsic failure of the heart or could be secondary to vasoconstrictor shock. In this situation, we have low systemic blood flow, but with high or relatively high systemic vascular resistance and unaffected pulmonary blood flow and pulmonary vascular resistance. In this situation, you can diagnose by normal pulse pressure, and maybe later on late hypotension might affect all of the blood pressure variables. Also low cardiac output by echocardiography, but normal diastolic blood pressure, sometimes high, and normal pulmonary functions. As you can see early, you have normal pulse pressure. Later on, you have reduced or normal pulse pressure, and all blood pressure variables are low. Medications that can be used, nootropic medication like Merinone, but if the blood pressure drops, you have to be very careful because Merinone is a strong vasodilator. Or you can use inotropic with the vasodilatory effect like dobutamine. Adjuvant medication to control the fluid balance and treat the underlying cause. Common scenarios, post-transition failure in preterm infant or hypoxic ischemic encephalopathy, less common in post-PD ligation and pulmonary hypertension. And then the common mistakes, use of vasopressors. Typically, you need to use vasodilator in this case. So dopamine or norepinephrine medication with the vasopressor effect might not be helpful. You need to use dobutamine or Merinone. And then the second mistake, delayed detection of the case at the early stages, and then later on the blood pressure might drop, and you may need to use dual medication, one to vasodilator and the other medication to support the blood pressure. And then we have restrictive physiology or cardiac tamponade. Cardiac tamponade can be by pericardial effusion or pneumothorax. Typically, in this case, management is to drain the pericardial effusion or the pneumothorax by appropriate chest tubes. In this case, you have low systemic blood flow, but normal vascular resistance in both systemic and pulmonary, and also normal pulmonary blood flow. And it also can be obstructive, and obstructive as part of the anatomic pathophysiology. Obstructive means obstruction of the outflow of the heart, which is common in left hypoplastic heart syndrome or coarctation of aorta. You may have low blood pressure and usually very narrow pulse pressure in this case. So you may have high systemic vascular resistance, which is a physiologic compensation from the body to maintain the blood flow, and then normal blood flow and normal pulmonary vascular resistance. Here you have two variables, normal pulse pressure and low cardiac output, but normal diastolic blood pressure and normal pulmonary functions. When you look at the blood pressure tracing, it's very narrow, high diastolic blood pressure and very narrow pulse pressure. So the blood pressure looks like just one line. Medications, prostaglandin typically to keep the PDA open and urgent surgery referral, adjuvant medication control fluid balance, and increase pulmonary vascular resistance, because now the systemic circulation is dependent on the PDA. So you need to keep the pulmonary vascular resistance higher to shift the blood to systemic circulation. Common scenarios, coarctation and left hypoplastic heart syndrome, and common mistakes, use of nootropics should not be used in this case, or medication that might lower the pulmonary vascular resistance like oxygen, and typically nitric oxide is contraindicated. One of the issues that you may see detect the patient clinically with the pre and post electrical saturation difference, and you may assume this patient with pulmonary hypertension. But with skillful clinical examination, you may diagnose hypoplastic left heart even before echocardiography. High pulmonary vascular resistance, which is typical pulmonary hypertension. In this case, you have sometimes low systemic blood flow, but typically the main problem here is high pulmonary vascular resistance. And in this case, we may have hypoxemia, oligemic lung fields, and normal left heart performance and lung ventilation. Medications that can be used, nitric oxide, alternative vasodilators if you don't have nitric oxide, adjuvant medication like sedation or treat any underlying cause, and then common scenarios, BPHN. It could be also atypical pulmonary hypertension in HIE or CDH, congenital traumatic hernia. Common mistakes trying to increase the systemic blood pressure. If you see pre and post ductal saturation difference or the PDA right left, trying to increase the systemic blood flow to reverse the shunt. This is completely non-physiologic and wrong. You should not do that. You should only try to reduce the pulmonary vascular resistance, because increasing systemic vascular resistance might increase the afterload and might lead to heart failure. The second mistake, trying to increase the pH to be alkalotic. Alkalosis, it might be pulmonary vasodilator, but at the same time, it will reduce the oxygen delivery at the tissues, because it will shift the oxygen distribution curve to the left. It's a very simple case scenario to keep in mind: shock in infant who was initially stable, discharged from NICU or discharged from the maternal unit, and then crashed during the first week of life and came to the ER with shock-like features, which could be functional or structural, left heart syndrome, and it could be septic shock. So you need to do septic workup. But in this situation, you may need to consider prostaglandin if you don't have echo accessible and it can be done right away, because the coarctation is high likely condition or diagnosis in this case, and prostaglandin is life-saving. Avoid over-oxygenation, avoid pulmonary vasodilators, particularly if there is pre and post ductal saturation difference in this case, because the systemic circulation is usually dependent to maybe 90% or more on the ductal flow. So summary of cardiovascular medications that we discussed in this presentation. So we have vascular medication, myocardium-related medication, blood flow-related medication, and medications that help with the reactivity of the vascular tone. So vascular medication, vasopressors, norepinephrine and vasopressin, or vasodilator like dobutamine or marinone. Myocardium-related medications, inotrope, epinephrine, or dopamine. And then load-reducing agent like diuretic or afterload. Typically, dopamine is not being used in most of the units. We are relying mainly on vasopressors or norepinephrine in case of clear vasodilatory shock. You may use epinephrine in late detected cases or significant hypotension. But dopamine is not a medication commonly used now, not commonly used in most of the units. And then we have the blood flow, the medication that can balance or shift the blood flow from systemic to pulmonary or other way according to which blood flow is low, prostaglandin during the first few days after birth. And then arrhythmia, use antiarrhythmic medication in case of tachyarrhythmia, or the opposite when you have heart block or severe bradyarrhythmia. And then reactivity, it means that the medication that can increase the responsiveness to circulating catecholamines like steroids. When you have severe vasodilatory shock, you may need to add hydrocortisone to increase the sensitivity of vascular tone to the catecholamines. And also, you need to get the pH normalized, because in pH less than 7.2, you might not get a good response to circulating vasopressors. And for that, you may need to use sodium citrate or acetate. Thank you very much.
Thank you, Dr. Yasser, for amazing presentation. Can I ask you the first question?
Sure.
It came to my mind that how can the multidisciplinary cardiovascular medication stewardship, if you can planning to do a stewardship program, how this medication, the multidisciplinary cardiovascular medication stewardship, if you want to do the program, what's your vision? How it improve the safety outcome in units with cardiovascular condition while minimizing the adverse event and adopting drug efficacy in this vulnerable population?
Yeah, that's wonderful questions. Thank you. Thank you very much. Probably because our time was limited, I did not present our data that we published on two different eras. So before we started our hemodynamics program, that's probably more than 10 years ago, we were relying, like most of the units, on empirical use of medications, like using dopamine or dobutamine in most of the cases without any physiologic insight about that vasodilatory shock or vasoconstrictor or cardiogenic shock or hypovolemic shock or any other underlying the cause that might be missed, like pericardial effusion. I remember a long time ago, before we implemented point of care ultrasound, we missed at least for the 1 day or two cases of pericardial effusion. So before we did actually analysis on the outcomes, comparing the first era, which using empiric medication without any clear stewardship of cardiovascular medication, and we found that the outcome, the short-term outcome, was number one, the time to clinical recovery was reduced by 50% when you use a specific medication, and using only one medication instead of using multiple medications. That's number one. Number two, the number of deaths actually decreased, although the total number of studied cases was not powered enough to study mortality as an outcome. But there is a trend of less deaths compared to the first era. So we compared the 3 years before we implemented the program and 3 years after we implemented the program. I can share the study in the group, and this study was done not only on cases of shock, it was done also in PDA and pulmonary hypertension. So what happened after we implemented our program on PDA, we were using a lot of medications and also PD ligation in a lot of cases. And after we implemented the program, less number of medications and also PD ligation became a history in our unit. We are not doing PD ligation anymore. We are more tolerant. And most of these cases of the PDA closed by itself or only responded to ibuprofen or acetaminophen without need for ligation. And pulmonary hypertension, before we implemented our stewardship program, we were using nitric oxide significantly, like higher than after we implemented the program. And it was used in a lot of cases just empiric. We are suspecting pulmonary hypertension based on only hypoxemia, but now we are using more targeted management. And as you know, nitric oxide is very expensive. It's $200 per hour supply, and some infants might stay a few days on it unnecessarily. So there's significant impact on our outcomes after we implemented our program. And that was not only published in our center, there's a lot of other centers publish the same data. So typically, it is also consistent with the new era of precision-based medicine, which you need to individualize your management, not assuming that one medication or line of medication can fit everyone. So you need to study the individual differences and the individual personal physiologic phenotype. As I described in the initial presentation, and probably most of us, we know now that precision-based medicine based on two main things: the physiologic phenotypes of different diseases, and also in some of rare diseases, consider genomics, which we are implementing now in some of the cases that we assume it is in very bad type of diseases, but it can be genetic related. For example, in chronic lung disease, infants stay on mechanical ventilation for a long time and require multiple interventions. It could be one of the spectrum of surfactant deficiency. So we apply or send for whole exome or genomic sequencing, and we get actually one of the genes responsible for surfactant deficiency is one of the determined causes. The same for ROP and the same for other chronic diseases. A lot of them that might be explained by different in genomics, or we can detect that, we can ask. We have now the privilege that we can send for these cases for whole exome sequencing, and we get the result within short time.
Okay, thank you.
Sorry, I explained probably beyond your question, a little bit more details.
Have time for extra question, Dr. Sameh?
Yes.
Okay.
Yes.
Anybody have a question? Or can I ask another question?
You may ask another question.
Okay. Once we talk about the we hear the presentation about antibiotic stewardship, which is overlap with the program, cardiovascular program, in the context of precision medicine, for example, when you are using the medication which impair the electrolyte and the nephrotoxicity, how you look for, is it integrated or?
Definitely, yes, yeah. So as we are working as a multidisciplinary team, the decision to use antibiotics in our center, probably most of the centers in North America, we have 3 teams involved in the decision making. They are very actively involved, not only the neonatologist, we have also the ID, the infectious disease specialist, who is really aware about the spectrum of bacteria that might be most commonly in a specific disease in our unit, like pneumonia or if you're suspecting meningitis. So usually we consider narrow spectrum to use the medication. And also we have the pharmacist, the clinical pharmacist, who is really involved in this decision. So if we are talking about sick infant, for example, with renal impairment or hepatic impairment or any other disease, the dose matters, and also the antibiotic matters. So we have to come on consensus that this antibiotic is more specific, more safe, and the dose is actually adjusted by our clinical pharmacist, and also review with us if we are using the medication inappropriately or for longer duration. We are not really allowed to do that. We are supervised by our pharmacy team and also by our ID. So I will give you an example that my privilege to order antibiotics, I have very narrow spectrum. I can order only ampicillin, gentamicin as the first 3 days of life. And for the late onset sepsis, vancomycin, gentamicin, I don't have privilege to even order cefotaxime without permission from the ID specialist. And I can order probably if any sick infant with septic shock, maybe 1 dose. But to extend beyond that, the ID person should be involved. And you can imagine that, like to order medication like meropenem or very strong wide spectrum medication, it should be really discussed on wider base before making the decision. An infant should be really very sick or like confirmed multi-organ. So it is a multidisciplinary team decision based on the case and also based on the disease itself or the pathology, that pneumonia, suspected meningitis or other disease, and also guided by blood culture. As Dr. Narvi said that when you have any sick infant, it should be full septic workup, including LP, suprapubic aspiration for urine, and 2 blood culture. We are not accepting 1 culture for late onset sepsis. Should be 2 blood cultures. So that definitely will limit the impact of resistance or abuse of antibiotics.
Thank you.
Thank you, Dr. Iman. So now Professor Yasmin Mansi will introduce the next speaker, Dr. Sameh. Dr. Yasmin, تفضل.
Okay. Good afternoon, good morning, everyone. I'm honored, طبعا, to introduce the next speaker, Dr. Sameh Tawfiq, a professor of pediatrics at the military hospital, and who happens to be, صراحة, the president of our conference, our great conference, the pediatric conference, pediatric update conference, the 5th year. And I have to take this privilege, Dr. Sameh, to congratulate you on the great success of this conference. And I know you've done such a lot of work, and the success of the conference wouldn't have been possible without your great efforts. So thank you very, very much. I attended yesterday, I attended today. I really think it was a very successful conference, alhamdulillah. I also